Okay. Good morning, ladies and gentlemen. Welcome to the Free Market Foundation, and thank you very much for attending today's session. It's fantastic to see so many people here. That's undoubtedly a function of the quality of the speakers that we have lined up. But I think there's also some serious concerns around the circular that was released late last year. And I think in true government fashion, government tends to have this uncanny knack of releasing really contentious proposals and bills right at the end of the year, just before the start of the festive season. And I think this latest circular is certainly no different. So I had the pleasure of introducing you to today's speakers, but before I do so, I'd just like to make some high-level remarks regarding the circular that were published last year. I think in one fell swoop, the circular sounded the death knell for health insurance products, and it also scrapped the development of a low-cost benefit option that had the potential of reaching tens, if not hundreds of thousands of low-income individuals. So I believe that the proposals are shambolic, to say the least. They do not reflect a well-considered, balanced view on how to increase access to low-income consumers to quality private healthcare. As you may be aware, the Council for Medical Schemes and the Prescribed Minimum Benefits Advisory Committee is currently in the process of developing a prescribed minimum benefit package with a strong focus on primary health cover. And in the words of the Council for Medical Schemes, they believe that this is a more direct and efficient way of bringing affordable and quality healthcare financing packages to South Africans. I hasten to add that this package has not been costed yet. So this is an utterly implausible statement, because how can you say something's more affordable if you have no idea what it's going to cost? So the new package also presumably adds new benefits onto the existing prescribed minimum benefit package, which also blows out the idea that it's going to be more affordable. I think we should be concerned by the fact that the regulator is currently in disarray and lacks the technical capacity to actually conduct the technical work that's required in order to finalize the new package by its self-imposed deadline of March 2021, which is a mere 14 months away. And for evidence of the regulator's capacity constraints, we only have to consider the fact that the Medical Schemes Act requires the council and the regulator to conduct a review of the prescribed minimum benefits every 2 years. And as far as I can recall, the last review took place in 2010, and the Minister of Health at the time refused to sign off on the package. So the current review started in 2016, and they still haven't finalized it yet. So that does not bode well for reaching the deadline of March 2021. Just to wrap up from my side before I introduce you to Adrian, I think the latest pronouncements by the registrar, who is supposed to be acting in the best interest of consumers, will only serve to harm them by denying consumers access to the products that they voluntarily choose to purchase with their own hard-earned money. And they reveal what many people, including myself, have long suspected regarding the government's true intentions, and that's namely to destroy the private financing mechanisms, which are obviously act as the main vehicle for accessing the provision of private healthcare services, to make way for the government's national health insurance system. On that note, I'd like to introduce you to our first speaker, Adrian Parsons, and because he's a new speaker at the FMF, I'd like to read out his biography before I invite him up to the podium. Adrian has been in the employee benefits industry for over 20 years. Prior to joining Kusa Consulting, Adrian was responsible for all business development within the JLT South Africa group. He was an executive director and owner of Ulika Consulting, which he sold to JLT. He has also been the managing director of healthcare at NMG Consultants and Actuaries. Adrian's key focus is on growth and distribution of the business for Kusa Consulting, and his experience is gleaned from consulting to some of the largest blue chip and state-owned organizations in South Africa. Adrian has seen tremendous legislative change over this time, some change adding tremendous value to all stakeholders, whilst other changes detrimentally affecting those that it was intended to assist. There's a depressing sense of deja vu right there. As part of the corporate healthcare strategy, legislation will form an integral part of the overall design, and Adrian understands the fundamentals of the basic framework necessary to create healthcare policies that work for corporates and members. These members will utilize various ancillary products necessary to fund their own healthcare expenses, which Adrian has introduced into many employee bases. And on that note, I'd like you to join me in welcoming Adrian up to the platform.
Thank you. Right. Thank you, Jason. Good morning, everyone. It's very encouraging to come to an event like this and see the participation of this forum. I mean, the legislation that we're going to be chatting around today, the implications are immense for employer groups, as well as all of the people who are currently using these products, as well as those who can't afford to use these products. So as Jason mentioned, what I'm going to do today is I'm going to have a look at this from an employer perspective, because that's what I've done for the last 20 years. But it shouldn't be underestimated what this means for the employees and therefore the members and therefore society. So I'm going to look at it from that perspective, but understand that it makes sense because it affects everyone. In addition to that, I'm going to do things kind of the other way around. I'm going to start off by just speaking around a couple of the fundamental numbers and statistics that exist in South Africa. And then straight after that, I'm going to go into what we believe could be a possible solution. So there's a lot of controversy around circularity and why it will or won't, and mainly won't work. But we believe that there's a myriad of solutions if we just prepare to explore them. Once I've explored that solution, what I then really like to do is go into, well, if we do go for these type of solutions, what does it mean for the employer? And therefore, what will it mean for those members? So in South Africa, there's 57 million people. We know that. 21 million taxpayers. Wow, already there's a big difference. We collect 1.2 trillion rands worth of revenue from the tax-paying base. Inside of the healthcare environment, there are medical schemes. Inside of medical schemes, from a principal member perspective, there's just over 2.3 million principals worth 4.9 dependents that are attached to that. In the low-income environment, numbers have been bandied about, but there's more or less, for the products that are affected by circularity, 1 million or so odd people who are currently making use of them. Inside of employer groups, we're seeing a kind of a myriad of either a medical scheme or a hybrid of a medical scheme and a low-income type product. And remember this, guys, anyone who's making use of healthcare in this country is employed. There's very few unemployed people who have the ability to go and fund themselves for private healthcare. So what I'm going to do now is I'm going to break down what could possibly work in South Africa from the healthcare figures that exist, what it means inside of public and private infrastructure, what these numbers mean, what NHR proposes, and then this massive balance that we have between the have and the have-nots. So everybody thinks it's the Gini coefficient, but really what we're going to talk about inside of the healthcare environment is what is spent from a private perspective versus a government perspective, and what it means for a member. And if we're prepared to explore and understand how we could impose possible solutions, what that would mean for healthcare, particularly as an employer group. So I'm going to look down a little because there's a lot of numbers. But in South Africa, there are the South African healthcare figures. There's 4.1 trillion rand as a GDP. That's just over 6,000 rand per person. Almost 350 billion rand of healthcare spend, which is 8.5% of GDP. And SA ranks kind of in the middle of annual healthcare spend. I know that's deceptive because inside of that healthcare spend, we know is the imbalance between the haves and the have-nots. So let's understand, if we know that that's what's being spent and we know that there's this imbalance between the public and the private sector, let's explore that a little. So inside of the public healthcare system, 4.1% of GDP is spent inside of that environment, as opposed to the private healthcare sector where it's 4.4%. There's not a massive difference there. Where the problem exists is this 4.4% needs to cover 84% of the population in South Africa. Whereas in the private healthcare, it's only 16%. That argument right there is what government came to us with and said, this is the rationale and reasons for NHR. There's no one in this room who can dispute that in South Africa, there's a dire requirement for lower income people to have better access to healthcare. We're not going to run away from that, and we all support it. And this is government's rationalization of that. So what does that mean? These guys who are using 84% of GDP, they're getting approximately 300 rand a month as far as healthcare spend is concerned. Whereas in the private environment, these 16% of the guys are getting around 1,600 rand per month. That's where the bigger difference exists. So from an employer perspective, we understand that this is a hell of a lot of money, and we understand it from a private perspective. People can't afford to go pay more and join medical schemes. So what does NHR propose? NHR has come to us and they said, but by 2026, there needs to be equal access and a standard level of benefits for everyone, all South African citizens. So if we had to say, okay, we're going to do that, but let's give everyone the type of healthcare that we're used to, that would mean that we need to give them 1,690 Rand per month. And what would that mean? 1.1 trillion Rand added onto the current bill, which nobody can fit. If we wanted to try and raise that, current SARS selection is 1.2 trillion. We would need to go and find another 779 billion Rand. 65% increase in our tax bill. So the healthcare that we receive on medical schemes, which we all complain about, there's a whole lot of people, if we try to bring everyone up to the level which we're complaining about, that's a 65% increase in the current taxes. It simply won't work. Doesn't make sense. So as I mentioned when I started this chat, what we do is we focus on employer groups. That's what I've done for a living. So let's understand what's happening inside people who are employed. There's 10 million employed people inside of South Africa who are employed but relying on public health infrastructure in order to meet their healthcare requirements. That's a lot of people who are receiving money. It may not be a lot of money, but they're receiving money, but they still rely upon the state. So if we took these and provided those 10 million people with a low income option of only 300 Rand per month, I'm sure a lot of you understand what these products look like, but inside a lot of the products provided, there's unlimited day-to-day, there's some chronic, there's some dentistry, there's some optometry, there's Rand values inside of hospital claims. It's much better than having nothing. But that can be provided for 300 Rand per person per month. If we had to go and do that, it would increase the annual healthcare spend by 3.4 billion Rand. But it leads to a reduction of South African citizens relying on the public healthcare up to 63%, resulting in a 25% increase in public healthcare spend. I'm speaking about these numbers like they're small numbers, but they're not. If you have a look, that would increase 40 to 41.2 billion, but it's a lot better than 1.1 trillion Rand. So what I'm saying is for 300 Rand, we have employers who are willing to take their staff, put them onto these products and provide them with a basic level of cover, which is better than what they're receiving inside of the government institutions. But we have a circular that's just been released that says we need to terminate these products. It seems counterintuitive that government isn't supporting these products. It seems counterintuitive that government doesn't want to relieve the burden by pushing it onto the private sector for 300 Rand per person per month. In order for this thing to work, there obviously has to be cooperation and a strong working relationship with government, but we've seen it happen elsewhere. Taking into account what's happening inside of the SOEs in this country, which I'm not going to harp on about it, we know it's happening in Eskom and Denel and SAA and so forth, it seems that there isn't sufficient funds to keep the things working that we already have in place. But we're going to go build something new that's going to cost more. We already have something that if government and the private sector collaborated on, we could grow and could cover a lot of these bases. Enhancing the level of universal healthcare services to a much larger base, which is part of the ethos inside of NHR. Allowing a realistic healthcare taxation solution to be explored. Tax are attached to these products, so we increase the revenue stream into government. And utilizing these funds to upgrade and maintain public infrastructure. Inside of Circulate, there's a lot written that this doesn't exist, and I want to touch on that because I think that there is a massive opportunity that's being missed inside of that. So, as I mentioned, deal with employers. What's the employer experience with regards and the upside of having these products? Well, medical schemes, low-income products, and healthcare hybrid options already exist. If you have a look at a lot of the medical scheme, as well as the administrators that exist in the South African environment, they've already adapted. They already have a medical scheme and they already have a low-income product. Members already have the ability to move between these two products free of underwriting and waiting periods. They have already dovetailed EAP programs onto these. I've been to one of the employer providers who's included on-site clinics inside of this environment. So they've already adapted to it. Integration and provision of benefits to members who would not have got it. From a broker perspective, when people participate in these products, they get assistance from the broker. When claims aren't paid, we help them. If they don't understand how it works, we educate them. That doesn't happen in the public healthcare system. There's no one to lead on. And consolidated reporting for employers. If somebody's going to spend money, they want to understand what the return on investment is going to be. They want to understand what it does for absenteeism, productivity, and so forth. All of these products cater for that reporting. Again, lacking inside of government. So what happens if we take this thing away, and I don't have to harp on this slide? The burden that exists from an individual perspective on the state is massive. It's obviously going to increase unless a solution is provided at the same time. Social insecurity and disbelief in state capacity doesn't only exist in the healthcare environment, but in many other environments where solutions haven't been proposed that work, whether it be our power utilities or whether it be our national carrier. The negative impact on absenteeism and productivity, the employers sitting in, the product providers sitting in this room will know about. It's been proven. If you have a provider in place, your staff member is not standing in a clinic the whole day waiting to be seen, and then the next day standing there again in order to collect his medication. Increases in misdiagnosis inside of public infrastructure has increased tremendously over the last 7 years, leading to a reduction in the mortality rate, an increase in the mortality rate, sorry. So the implications have been measured. And lastly, when we say the increase the burden, this is the increase the burden on the infrastructure of state, should these products be taken out. So we spent a little bit of time, we sat down and I want to say we had a couple of beers because it was kind of fun to read. And we took Circulate and we went through all of the reasons why these products should not be allowed and what it meant. And we said, okay, let's just unpack it, because often we sit on the private sector side and we say, are you mad, are you mad, are you mad? But if you take a step back and a deep breath, they could be correct. So let's unpack what Circular 80 says a little, okay? It says inferior benefit structures and state DSP usage with no agreements. If you read it, it's saying, so many of the providers, not only from a low-income perspective, but also from a medical scheme perspective, provide benefits that the member needs to go and receive inside of state facilities. The problem is there isn't a contract between these two entities, so the state is providing the service without receiving remuneration. So therefore, let's scrap the product. Wow, I think that's throwing out the baby with the bathwater. If we don't have a contract, it's an admin issue. Let's go put the contract in place and police it. Because by doing that, guess what? There's a benefit provider and they're going to get paid for it, and the government needs money. Secondly, regulatory arbitrage and opportunistic product design. So that's funny. They're saying, as corporate South Africa and product providers, we're undermining the medical schemes, because inside of the medical scheme environment, we have community rating. So community rating inside of a medical scheme says, if you and I are on the same plan, and I'm sick, old, and ugly, and you're young and healthy, on the same plan, we're going to pay the same contribution. Therefore, the way that the medical scheme works is it relies upon cross-subsidy. If we're all going to pay the same, they rely upon the fact that younger people will claim less and the pensioners inside the scheme will claim more, and they'll find some type of equilibrium. But inside of the insurance environment, it's risk-rated. So therefore, you're able to price it slightly more competitively, and you're going to be moving people in between the two environments. Okay, so pick one. Pick one, and then that problem's gone. And secondly, again, as I pointed out earlier, the medical schemes don't seem to think that this is such a big problem for them, or they wouldn't all be rushing in with their own low-income products on their own already. So that kind of makes sense. Also, and I know this is where I think Mark's also going to go, if you're going to take this thing away, then surely at the same time you say, well, here's the solution. The unease that it's causing, and again, from an employer perspective, we sit with our guys at the beginning of every year and we make certain that the healthcare strategy that we exist can flow for the next 3 years. And this is a hell of a thing because of all the reasons that I've already explained as to why it affects productivity and absenteeism and so on. When you take it away, you're unable to continue with that design. So what do employers want? Employers want benefit integration. They want to know that everybody, from the execs all the way down to the guys working on the factory floor, will have some type of cover. And currently this is available at 300 Rand a month, if not less, on some of the products. A lot of these product providers from a medical scheme and low income perspective have stress management programs included in it. Psychosocial claims inside of medical schemes are increasing 50% year on year. And what? It's related to stress, which is related to finance, which is related to the economy. There are benefits available for it inside of these. Wellness days and providers are included in these benefits on an annual basis. There's proactive screening and testing of all of these employees. It lowers the disease burden. It lowers your risk rates inside of your retirement fund. It increases productivity. There's so many reasons to have it. Health trends and interventions, as I've said, the analytics provided inside of the corporates through these providers is not what you would receive out of government. And as I mentioned, absenteeism improves. So guys, you listen to me a little, I'd just like to end off on one note. Over time, we have seen government propose different pieces of legislation. And as Jason said, we've seen some of it come to fruition and it's been good. And we've seen some of it come to fruition and we thought, what is government doing? And right now, the grey area and lack of clarity, no one really knows what's happening. Should they chase this route, the legal implications for government are immense, because we can already see how many pieces of legislation they'd be contravening, but they can change legislation. So instead of looking at the glass as half empty, at KUSU we have a philosophy. Every time we've seen this stuff happen, the private sector is fleet-footed enough to come up with a solution. When finances, well-being, your staff, your family are involved, we make a plan. So I'm going to leave you with that because there isn't enough for us to say these are the solutions. But as this progresses, we'll be following it, tracking it, and looking for those solutions. Thank you. Thank you.
Our next speaker is a good friend of mine, Michael Settas. And he's a regular speaker here at the FMF. So if you're not familiar with him, please take some time and read his bio in the invitation. But I'd like to welcome him up to the stage now.
Cheers, thanks. Morning, everyone. Or is it afternoon already? I think it might well be. With all these regulations, it's hard to know the time of day most of the time. So. Anyway, so just to start off, I think it was an old Chinese proverb that said, may you live in interesting times. Well, I think for us in the healthcare industry, there's constantly interesting times. So it never seems to go away. So let's have a look at what I'll touch on today. Circular 80 is stating that those people who are on exempted products are going to be taken off and there's no kind of plan for where they're going to be. So they're going to ostensibly go back to the public sector. So let's have a look at the public sector. Also, I think what this all talks about is our health policy as a country. To say the least, it's seldom consistent, it's seldom logical, rational. It always seems to have a strong ideological bent to it, which creates problems in itself. Let's have a look at the implications of Circular 80 as directly as such. And then also, I think what's worth looking at other countries. What do other countries do in terms of health policy and the practical implementations that they look at there in terms of bringing healthcare? Healthcare is something that everybody wants, the whole world. It's a very consistent, buddy motive product and policy. So I'll just start on public sector. Some of you have seen my slides before. I've touched on this a few times. Where's the public sector and how good is it? So this is a report from the Office of Health Standards Compliance, which exists within the Department of Health. And it tells us, it gives us a clinical picture of those facilities that it inspected. There are about 700 that came in the 2018 report. You could almost think about the office as an auditor, a clinical auditor general. Now remember that what government is saying is to qualify for NHR, all facilities, private and public, must score 80% or more on this scale to achieve accreditation, to work within NHR. So this is the scorecard that came out of 2018. So as it stands now, out of those 700 facilities, 1% can contract with NHR. So I'm not going to harp on about this other than to say, I mean, the graph itself is self-evident. But how do you build a national health system when 99% of your facilities, by your own design, you're excluding because they're not capable of delivering the care that's required? And secondly, maybe add a second point, why is government not focusing on fixing this rather than spending so much time in terms of health policy that seems to have no constructive or certainly a beneficial need to actual tax the citizens of the country, people on the ground. We can measure public outcomes as how we compare with other upper middle income countries. And the two measures we look at here, and they are fairly standard measures to define the state of a healthcare system. That's infant mortality and maternal mortality rate. And how we compare with other upper middle income countries, our rate is 2.5 times worse in terms of infant mortality. And even worse in terms of maternal mortality, we're about 3.5 times higher there. And that shows also in another factor, which is our overall disease burden. South Africa's disease burden is the 19th highest in the world out of 196 nation states. Now, the more effective your healthcare is in delivering, the better your outcomes, the lower your disease burden goes. So that tells us that we're not really having an impact in terms of the disease burden, because the healthcare is not there. Let's touch on medical malpractice liability. So I call it a substantial and growing problem, because there you can see the numbers as they progress. They're escalating at an alarming rate. Now, this could become the Eskom debt for the Department of Health, because if that does carry on at that trend, that's only 5 years. It's gone from 28 billion to now nearly 100 billion. What happens when it gets to 200? What happens when it gets to 300? We've got big, big problems. And people aren't going to go away on this. It needs to be resolved. Just to put perspective on it, the entire national budget for the 2018-19 year is 226 billion. So that liability, although it won't be paid out in 1 year, it sits on the balance sheet just like debt does. Consumes 43% of 1 year's budget. Look, I don't know how to fix it, but geez, it's got to happen sometime soon, because that could be a major problem. All of this, very disconcertingly, all of this is happening in the face of the complete opposite of what we constantly get told, is that there's not enough money to employ. We can't attract more doctors. But this is a document put together by Treasury, amongst others, that shows from March 2006 to March 2016, there was a 42% increase in the number of medical personnel employed by the state. These are not posts. These are actual employment figures of medical personnel. So we have to ask the question, why has it got worse? It doesn't make any sense. And then just some insider views in terms of it. The Health Ombudsman wasn't very nice about the Department of Health, and the Auditor General was even less kind about it. The emphasis I'm trying to make here is that the people who sit on the exempted products, the figures kind of vary, but whatever they are, it's substantial, are now going to be told, give up your private care, and this is where you've got to go back to. I don't think it would make anybody happy, would it? So not a great picture. Okay, SA's history of health policy. This is important, because I think health policy is really the issue that is so segmented, it's inconsistent, it doesn't seem to follow any plans. We keep jumping around on it. So I thought, let's go back quite a few years. I went back 25 years. So I thought, let's start in 1995 on my timeline here. And there was a policy paper written by the ANC just after they'd come into power. And it really spoke about a very social structure in terms of healthcare. Nothing much ever happened with it. It's really nothing was implemented. A few years later, what was to eventually become the Taylor Commission, it started in terms of its investigation, and its broad mandate was to look at social security in South Africa. It wasn't just healthcare, but healthcare was one of the components. In 1998, the Medical Schemes Act was promulgated post the Malpractice Commission, which was put together to redefine the space for the medical schemes to operate in. I'll come back to that just now, but to explain how that was done. The Taylor report, another few years later, then came out with its final report, and within that, in terms of the health component, it spoke about establishing a social health insurance fund. Now, the essence of this was that the medical schemes would stay where they were, as voluntary and available to whoever could afford it. There would be a social health insurance fund, which would sit below that, would be funded through a payroll tax, and that fund then could purchase care from either the public or the private sector. And then the state public facilities below that would remain for those who were indigent, the elderly, the poor who couldn't, unemployed. Okay, it represented, in my mind, the most logical, rational, affordable, workable structure that we've ever had. Okay. A year later, LIMS starts. For those of us who've been around in the healthcare industry long enough, that was the low-income medical schemes. It was the precursor to LCBOs. So I just want you to look at that date. 16 years ago, this was proposed. And where are we now? We're back to it being canned again. So LIMS didn't last very long. It was dumped on some spurious concerns 2 years later, so that just disappeared. Let's have a look at another, what we've got there, 12 years, I think. 2007, coinciding with the Polokwane conference, in which the power changed in the ruling party. The left got a bigger voice. SHI was abandoned, okay, and it was replaced the following year with NHI. Now, a name by another rose, what is it? Like a rose by another name, I should say. What's the difference? Okay, the left hated SHI because of the payroll tax. NHI was going to be free at the point of service and free, nobody was going to pay for it. Utopia. But it's interesting to see now in the NHI bill it's proposing payroll tax. We can't get away from it. But it just shows that the vacillation in policy, all based on ideology, keeps replacing stuff that could have worked a long time ago. The NHI Green Paper was published in 2011. There were 2 subsequent white papers, which I haven't shown on here, just out of space, but essentially the white papers were a carbon copy of the Green Paper with some bits and pieces changed around it. In 2015, LCBOs starts and ends all in the same year. Okay, LCBO, as I said, is the low-cost benefit option, and LIMS was the precursor to that. And again, it was ended just at the end of 2015, just before the one white paper on NHI came out. And subsequently, we did discover it was on direct instruction from the Minister of Health then to end the LCBO. 2017, LCBO restarts only because the demarcation regulations were published. So because of that publication, there became a constitutional issue around the people who were sitting on the low-cost, on the insurance products, these low-cost insurance products. So when that restarted, they had to create this demarcation exemption framework, which exempted the insurance products until government got, or the Council for Medical Schemes got LCBO started. So it was an interim play. 2019 then was a busy year. We had the NHI bill, which was passed by Cabinet to go through to Parliament. The Health Market Inquiry finally published its findings after almost 6 years. And then, of course, our now famous, infamous, should I say, Circular 80, okay, and 82 on top of that. So I want to talk about this. In the red circle there, it is the only piece of legislation in 25 years that has actually been passed, or major piece of legislation in healthcare, that focuses on the delivery of healthcare in South Africa has been passed. And even then, they didn't do a very good job of it, and I'll tell you now. The Malamat Commission proposed a structure which had the principles of social solidarity being open enrollment, community rating, PMBs, but also mandatory coverage and risk equalisation. But again, we come back to the point that the unions, the left, hated the mandatory coverage point of view because we're going to force people into the system. So they just decided to drop it and then implement the rest. So it's like having a car with 3 wheels. It kind of goes along, but really not very well. And it's part of the reason why medical scheme costs, a significant reason why medical scheme costs have escalated so dramatically since 2000 was when the Act was actually applicable. And then again, not once and not twice, I sound like I'm auctioning here, but 3 times. The industry has decided to try and start to expand healthcare, private healthcare to lower income people, and 3 occasions we've had it taken out from under our feet because of, we're not really quite sure, to be honest, most of the time. Okay, so I just want to touch here on the National Development Plan. We won't talk about that NDP, but one factor in it which kind of struck a chord with me at the time when it was published was that there was this big red line that said, let's draw a distinction between this, public service administration and political interference. They need to be separated. I was very intrigued that out of the ANC Lekgotla this weekend, Cyril, our president, came out to say, we need to have this. We need to separate political interference, keep it away from public service administration. So if that is the case, and it's now being put as a point that we need to achieve, why has the NHI bill been written in such a way that the way it's been written from a governance point of view smacks entirely of political interference? It is at the behest of one person. Whoever holds the post of Minister of Health will have total and complete control of how the NHI and the NHI bill operates. It flouts every single good governance law, no separation of powers. It's going to be a problem. So why have they written it like that if that is the policy principle? So CMS Circular 80, to my mind, smacks of political interference. Maybe we'll find out at some stage, I don't know, but we'll see. And then I think lastly, in terms of this sort of subject point, is this politicizing of universal healthcare. We need NHI because we need universal healthcare. Not true. Okay, very simply, the two issues are completely separated. We, in fact, already have universal healthcare in South Africa. The World Health Organization accords us a rating on a scale of I think, 0.67, 1 being perfect, 0 being non-existent. It's the mechanisms by which that's healthcare service delivery is made, which is malfunctioning now, and that's largely in the public sector. And equally in the private sector, although the private sector works well, it's only affordable to a very small percentage of the people by virtue of its high cost. Okay, so enough of me getting a bit worked up there. Impact of Circular 80, let's have a look at this. So before we touch onto that, let's look at this issue of medical scheme affordability. Now, I looked at the tax credits claimed here by assessed taxpayers. Now, another point is alarmingly, this has dropped as well. There's only now just about 5 million sitting in this category. And if we look at those are the income levels on the left, and this is the percentage of people who claimed a tax credit. So you can see below 150,000 Rand a year, there's very, very few people who really are able to partake within medical scheme coverage, and most of those would have been because of subsidies. So if we have a look over there, this is where an employer subsidizes the medical scheme. So most companies have moved away, I'm sure Adrian would tell you this definitely, from subsidies to cost to company. So the subsidies have essentially fallen away. And if we look, we get a very, very similar picture here as well. Below 150,000, there's just simply no scope to have any cover. And in this category here, sort of nearly 3/4 of all taxpayers are sitting here who are on medical aid receiving a subsidy. And that's certainly, I think Adrian touched on it, companies would love to subsidize their lower income, but they can't afford to because they just raise the cost of labor. Another factor then just to touch on is have a look at this graph of beneficiaries within the medical schemes industry, starting there at 1998 and going right through to 2017. So 2005 was quite a year. Something must have seriously happened there. Any guesses on what we're looking at there? Okay, for those industry players, yeah, we know GEMS started, so Government Employees Medical Scheme. So at the end of 2018, GEMS had 1.8 million lives covered on it. So that essentially is virtually all the growth that happened in the industry since then has come out of Government Employees Medical Scheme. But it's not because GEMS has something special that they do that the rest of the industry doesn't have. It comes at a cost. That is the subsidy from about 2 years ago that GEMS employees or government employees get. It's somewhere between 75 and 100% of the contribution, depending on pay grade, subject to a maximum of 4,600 Rand per month. I mean, would you like a subsidy like that on your medical aid every month? It's very, very generous. We're looking at 35 billion Rand per annum to subsidize medical scheme for government employees. So I think in the context of servicing Eskom debt, how far 35 billion Rand a year would go to servicing that debt problem. It would go quite a long way. So, yeah, I think some interesting points there. Health market inquiry, just to touch on here. So I don't think the Competition Commission and the Department of Health are very good friends anymore because the Competition Commission didn't really have very nice things to say. So, but the point is that they said there was inadequate stewardship of the private sector. I spoke about it earlier in terms of the Medical Schemes Act was implemented from the findings, from partial findings of the Malpractice Commission. So they took bits and pieces instead of putting it together. And they really emphasized that in their report to say that the private sector sits in this half-baked regulatory framework. It's got some good components, but some that needs to have implemented to stabilize it and bring costs down. So you can see there the comments that they had around the Department of Health, and as such, the private sector is neither efficient nor competitive. And the emphasis here is that if the medical schemes environment was more competitive, we wouldn't be trying to find these more cost-effective solutions because private healthcare would be more affordable. We could have more people in the system. The more people in the system, the less pressure on the public sector. So I think South Africa has been denied an expansive private sector by virtue of regulatory and policy failure systematically over a number of years. So the actual detail on Circular 80. So what does it say? So it was issued by the Council of Medical Schemes on the 4th of December last year. I think Jason and Adrian touched on the point is they like to time this nicely to just to really give us something to think about while we're trying to have a holiday, you know. Banning all low-cost products. So the low-cost products sit in, currently all the exempted products sit in this thing called the Demarcation Exemption Framework, which is an interim exemption given to insurance companies by the Council for Medical Schemes until such time that low-cost benefit options could be created within medical schemes. And the insurance products would then move into that once that process had been followed. And that started in April 2017, when the demarcation regulations came into effect. So what our Circular 80 is saying is that these products sitting in there will now end on the 31st of March 2021, only 14 months away. It's not very long away at all. And by my count, there are 13 insurers. The numbers vary. I said several 100,000 policyholders there. It seems to vary from several hundred to 1 million, some even more. We don't know. It would actually be interesting because the council's got all the numbers, so it would be nice for them to publish it so that we could actually see. So the concern we have here as an industry, I think, no engagement or discussion whatsoever. Bombshell, boom, here it is. I won't mention the name, but I understand that the person in council who headed up this division in terms of running LCB, I didn't even know about Circular 80. No alternatives or explanations given either, other than to say that this is a policy alignment with NHR. That's it, kind of the position. And also very selective reliance on the HMO findings. Even though the HMO findings weren't very complimentary of this very same department, they have selectively relied on some of the HMO findings to justify why they think Circular 8 should be is valid. So Circular 82 was a follow-on from Circular 80 with some product data and some indications of figures, all very quite generic. But it was unfortunately a broad sweep approach. Everyone was just painted with the same brush regardless of what your own, as a provider, what your own particular metrics were. This unilateral accusation of regulatory arbitrage. So, it's kind of an undertone of, the private sector's cheating and being nasty and chasing profit and not being fair to members. But I argue the simple point that this is a new regulatory framework that was created by the Medical Schemes Council at their own insistence. Okay, and no enforcement was done. There was also, it seems, a lack of intent to implement LCBO. So it's been nearly 3 years now that the framework started, the demarcation exemption framework, and very little has been done, if any work really, in terms of getting it going. And this kind of all again smacks to me of political interference. Somewhere along the line, someone's told someone, make it go away because it doesn't fit in with whatever our ideology is. We can say it's that over there. I think that might kind of give it tone. And do we need to say more about political interference? Just looking at those five entities there, if you can read them. That was the comment from the Auditor General this year. Worst audit outcome ever for SOEs. Okay, so the whole policy thing is moving towards getting the private sector away from delivering healthcare because we want to build NHR. But how can we build NHR? When we're sitting on these kind of figures here, budget deficits growing, growth is nowhere, inflation has kind of eased a bit now, and as if prime interest rates come down as well a bit, we see, which is good news, but still the picture's not good. And I think the real key issue is this one here, which really has been much spoke about problem and a real problem. Because if our debt carries on as it is, it was 26% of GDP in 2008, and it's grown at an alarming rate to 60% as at last year's figures, with a projection that it'll get you 80% within the next 5 to 6 years. Now, once you get to that point, you really start to battle to come back. The only good picture out of this is that the vast majority of the debt is in our local currency. So if the rand weakens, that debt is not growing virtually just by virtue of a foreign exchange rate. I suppose I should have clicked on that next slide there. Okay, so let's have a look at international experience. What do other countries do in terms of their health policy? And I think this is relevant because we're not an island nation stuck away somewhere on our own. It's very relevant. Just to touch on what was the policy analysis done by Department of Health on NHR? And unfortunately it was created in such a way that it was this binary assessment. And that was total privatization of everything, public as well, or let's have a state-run NHR. So it became this tussle between free market capitalism and the typical monopolies of socialism. Okay, obviously there was never ever going to be a leaning towards a free market capitalist system, and rightly so, it shouldn't have been there. But neither do I argue that it should go the other way to a complete socialist monopoly. Because if we have a look at the health policies and the practices of other countries, the reality is that they overwhelmingly sit in the middle. They have elements of free market capitalism, but they also have social structures which assist in terms of especially lower income and the poor. So we don't need to have this radical ideological divide between socialism and capitalism. It can really work in the middle. And I'll touch on some of those now. So I wanted to touch on single payer models, which is what the NHR is proposing. So one big medical scheme for the whole country. There are some of them that exist out there in the world, and I'll touch on them now. You get two variants of the type. One is what is called a complementary system, and that is where it creates a public monopoly. So monopolistic purchaser of healthcare for whichever fund that is for all the citizens in the country. And this is what NHR is proposing as being. The other type is a supplementary system where it says, we're going to have this national health system, you have to belong to it, but if you go and purchase your own private care externally, then you're welcome to do that, and you can use that private. And that entrenches a level of competition between the public and the private sectors in countries. So SA currently mimics a supplementary single payer model because we have tax-funded universal healthcare, but if you can afford it, you can purchase medical scheme cover and some health insurance externally if you don't want to rely on the public system. And what we're saying now against Circular 80 is that we want to maintain that status quo and expand this because it's going to help there, because you're going to have the same tax pool to cover less people. If more people are on private, then we obviously better for the country. Obviously, it's not going that way, and that's concerning. So let's look at these complementary single-payer models that are, according to some spokespeople in the Department of Health, is many countries have got systems like these. Okay. Okay, I could find 5. That means that 2.5% of the nation states in the world have decided to build a complementary single-payer model system. So it's hardly best practice all around the world. And if we look at those 5 countries, the first 4 are all developed economies. So their financial position's far better than ours. The last one is a developing economy, but I don't think I really need to say more than who wants to emulate Cuba as a model of best practice for the upholding of human rights. Okay, so it is the world's only developing economy with a complementary single-payer model, and we're trying to be number 2. There's good reason why we shouldn't be. So if we have a look at some international practice, I take Brasilia as also a developing economy. They have, like most countries, would have private funders, private providers, public funders. It's called the SUS. I don't know what it stands for, some acronym in Portuguese, and then public providers. But the essence of it is that private funders purchase care from the public sector, and conversely, public funders purchase care from private sector. Public funders purchase from public, and private purchases from private. And the essence of what I'm trying to point out here is that bringing universal health coverage is not a singular viewpoint of where only we can do it. And it kind of seems to be a tone of what South African government is that we want to push the private sector aside, and it's only we're capable of doing it. Even though our track record is not so great, only we can do it. Most hospitals in Brazil are privately owned, most of the clinics are public, and people use them interchangeably as they go. The quality is relatively good. It's not a perfect system, there is no such thing, but it works because it's collaborative. The private sector in Brazil is growing and has grown substantially for a number of years. Germany has a nationally mandated coverage package, like, say, equivalent to what, say, the PMB is within medical schemes. But every citizen, although they're obligated, has a choice of about 130 different sickness funds. Sickness fund being a non-profit entity, very much like a medical scheme. So they have choice in terms of where they want to go to. Even though that there's a national mandate cover, the government says there are 130 funds, whichever one you want to choose, it's up to you. Australia has a nationally tax-funded health system. They've actually created incentives, tax incentives, some sort of on penalty side as well, to the extent that 47% of Australian citizens now have private hospital cover, even though they have a nationally funded tax system. And the government has created the incentives to actually make that happen. And it's logical, because the less people rely on our limited tax resources, the better care we can deliver. Ireland, to touch on a note here, wanted to create a national health system. It was called the Universal Health Insurance. But after 2 or 3 years of work on it, they abandoned it in, I think it was 2015, if my memory serves me correctly on that one, because it was unaffordable to the country. So they said, let's go back to the drawing board. The principle's correct. We want to bring healthcare, but hey, this thing's going to cost us too much. We need to rethink it and go back. And I don't know particularly, but I'm pretty sure Ireland's reworking where it should be going. We've even said it doesn't matter what it costs, and we don't know what it costs, but we're going to go ahead in any case. It's rather concerning. These 4 countries were all outlined in the white papers as being examples of why South Africa should have a national health system. And let me emphasize the point here, because I don't want to sound like I'm saying we shouldn't have universal health coverage and we shouldn't be bringing care. Absolutely, it's a laudable goal, but there are very many ways in which it can be done. So these 4 countries here, Mexico, Thailand, Brazil, Korea, this bottom line here shows the average of tax base and unemployment levels. So there you can see nearly 30% tax base and unemployment levels at 3.8%. So if we compare that to South Africa, our tax base is now even less than 10% because it's shrinking. And I think we all know that our employment rate is now nearing 30%. Okay, these figures are about 2 years old. And then just let's touch on a few of these countries. What do they have in their health systems? So Korea, with its own metrics there, much better than ours, in their national health system have patient co-payments on inpatient treatment, that's in hospital, between 10 and 20% the patient has to pay, and on outpatient treatment anywhere between 30 and 50%. That's quite significant. So if the doctor charges 100, you're paying that percentage of what the doctor's charging. And on top of that, there's a payroll tax of between 5 and 10% that applies to 96% of employed citizens in the country. They are struggling with costs. How on earth are we going to fund a national health system to provide us with comprehensive care? In Thailand, the private and public sector split is roughly 35-65. So the private sector is a very significant component of their health delivery, and they need it to deliver their care. If we look at Mexico, out-of-pocket expenditure equals 40% of total national spend. And if we add the amounts paid to prepaid insurance, private insurance, then total private spend in Mexico is 52% of total national health expenditure. So the emphasis on this point is that it's virtually impossible for governments to go it alone on healthcare. To make it viable, to provide universal healthcare, to expand the coverage as much as possible, it is essential to have an as expansive a private sector as possible. I'm almost done, so I'm just going to finish on these last 2 slides. These are the out-of-pocket expenditures total national of 12 developed economies. Okay, so these are countries much wealthier than us, okay, per capita, significantly. Have a look at there. There's the out-of-pocket expenditure. France is the best, 17, quite substantial. Okay, so a lot comes from the private citizen using that tax-funded system. But now if we take those same numbers, the out-of-pocket spend, and we add what citizens spend on private insurance in those countries, we then get a picture of what the citizens spend out of their own pockets, whether it's out of pocket at the time of service or on prepaid insurance, as a percentage of total national health expenditure. Okay, so now you have a look at these figures here, and it tells you that the private money going into a country's healthcare system to deliver universal healthcare is quite substantial. I couldn't get to the weighted average because it was going to take me about 3 days to get all the numbers together. So I'll just use the unweighted average. But the unweighted average there is 25%. So that's 1/4 of all expenditure in those developed economies is coming either out of the pocket of the user, or the user saying, I want to buy private insurance to have my own cover. Okay. So why, if this is what developed economies need to get to balance the books for themselves, how would it be possible for us to think alternative that we could go it on our own? Okay, so I think I've waffled enough, and I apologize for that. So just in summary, NHI is an unprecedented model, as we saw. It's an international outlier. There's only one other country with a complementary single-payer model that is a developing economy, and the less said about that country, the better. Unrealistic in terms of, and I touched earlier on the governance, there's major concern about the governance structures within NHI. I will quote Professor Alex van den Heever, who's been a long-time critic, who said it's been designed for patronage. Okay, that's quite a statement to actually make. So Circular 80 to me is regressive and unconstitutional. It's taking people's rights away in terms of healthcare. And it's in total contrast to international experience as to what we've just looked at. So how are we going to do it any differently? Especially given our fiscal position that we're in now. The budget speech coming out at the end of next month, and I'm sure we were waiting for that. And it kind of smacks again to me of that thing there, political interference, and hopefully it can go away. Thank you very much for listening. I appreciate your time.
Okay, we're going to take some questions now. Would you like to pull up your chairs and come sit up here in the hot seats? Who would like to start? Does anyone have a question they'd like to ask any of our speakers?
We won't be in the hot seat for long, I promise.
Yeah. Okay, I've got one and then two.
Thank you very much for the presentation. They were excellent. I just want to know, we all know it's not going to work. It's going to be an unmitigated disaster. What is being done? Do you have any insight from the private sector side to try and stop it? So what are the steps that need to be followed and how successful do you think they could be?
Can I answer? Do you want to? I think what is the stance is that publicly we support NHI, we support universal health coverage. If you speak behind the scenes, I'm obviously not going to mention names. They're very worried, and I think they might sort of see how it's going to progress and where it's going to go before. I think the essence is that nobody wants to go to court, but if they're forced to, if that's the absolute last resort, I think they will. Because I can't see how this thing is going to work in its current form.
So you say that that's the last resort. Do you know of any organisations in the private sector that have taken steps to move in that direction?
I do think it was sort of convened towards the end of last year. Abusive put together a six-person delegation from private sector and 6-person from Department of Health. Unfortunately, I'm not privy. I think that it's a closed committee until they sort of put some comments out. So I'm not privy as to what the developments, if any, have been around that. But that is certainly a positive development recently. So
I also think individual stakeholders are doing it on their own accord. Discovery was with Treasury last week, and the discord between Treasury and the Department of Health is massive. So you don't know who to believe.
But I suppose given the political influence here, it's not going to be successful, surely?
Oh, it's hard to say. Look, I think the sort of standoff between Treasury and Department of Health has been long-standing. It's not. I mean, throughout the demarcation regulations, which started 10 years ago, it's always been a sort of rather tenuous position. I mean, if I can speak on their behalf, I don't know this officially, but I think the sense of it is they're looking at the fiscal side of things, which I touched on here, and are going, how on earth are we going to afford this? So rather let the private sector expand, because then we alleviate pressure on public system. And they would apply not just to healthcare, everywhere, you know.
Next question over here.
A couple of points, and then I'll come to the a question I have for you. My name's Rob Jeffrey. I'm a former MD of Econometrics. The great Tony Twine and I wrote a report on the NHI, I guess it was about 2010, 2011. It's unaffordable and will wreck the country. And just as a matter of interest, there are 3 things which will wreck this country: national health, nationalizing the Reserve Bank, and our renewable energy. Those are the 3 things that are going to have a tremendous impact. But one's got to look at the impact on investments and skills. There have been over 1 million immigrants, whether they've emigrated or just left, just gone to live elsewhere. That's about R1 trillion a year in GDP, or 0.5 to 1% per annum, is the cost of that immigration. Now, this country needs investment and it needs skills. And the one thing that will happen, as I've understood it, and this is part of the question, is if one moves towards an NHI, you will downskill first of all. You're going to create problems for doctors and the healthcare people themselves, and secondly, it's going to impact on skilled people. They'll say, well, I'm not going to come to a country where there's no medical health or very poor medical health. So my question to you is actually, when people cost these things out, do they take into account the tremendous, devastating impact on skills, immigration, and the skills of our medical health? I think all of us know here we have one of the most, I mean, I don't know about you, I'm on private medical health. We have one of the best medical fraternities in the world, I would imagine. And what's it going to look like in 20 years' time? And are those factors taken into account when you do all these sums? Because they are huge.
So I think there's quite a bit to this, but I think we're all singing from the same hymn sheet because we agree with you. Essentially, you're also asking, does government take cognizance of people who need to live and work inside of this country and their healthcare requirements, and if they don't get them, they will leave? And I think a large component of what people see inside of NHR and when it comes is an effect when they leave. But also, don't forget the people who work inside of these industries who will lose their employment. And again, there, we don't think government takes cognizance of that. We saw 5 years ago with single exit pricing, a whole lot of chemists immediately lost their jobs, and there's seriously only 3 chemists we can go to now. So I don't think that, from our perspective, or at least we're resetting that cognizance is taken of that at all.
Just one comment on that, Paul. And I know this is a hard-nosed, nasty economic view. The basic fact of life is that this country in particular, but there are many others, cannot afford equal health for all people. Full stop. There are just differences, and one's got to take that into account. That's just a harsh economic reality.
Mark, would you like to add anything?
Yeah, I think maybe that you mentioned about a costing. It's very concerning that on NHR, that we are now about 10 years after the almost 10 years after the green paper was produced, and there has been no comprehensive costing done on it, and that government just doesn't seem to have considered it to be important to do so, which is very concerning.
So Mark and I have done some costing, and I think our calculation came out at 456 billion, if I remember correctly.
Yeah.
And if we take into account that personal income tax, the total personal income tax take sitting at about 450 billion, which is considered the main vehicle for actually financing the NHR, then you start to understand the futility of the arguments of saying, okay, we're now going to pour in 456 billion rand into this system. Just on the matter of the doctors, I think we've seen an aging population. This is just my anecdotal, and we are intending and looking into something like this. But what we see, the last time I saw, I think the average age of the specialists in the country was sitting at about 56 years old. Yeah. And we can reasonably anticipate that stats got worse. So there's no new doctors that are coming into the bottom. And we're also seeing a lot of anecdotal evidence where doctors that have massive practice costs, so ophthalmologists, things like that, are choosing not to set up their practices in South Africa, and a lot of them are already immigrating, whereas some specialists like anaesthetists that don't have massive practice costs, they're sticking around and trying to work out, navigate the system and see where to go. So, I mean, you have to look at it in silos as well to get a picture of what's happening. But I think there's definitely a downward trend in terms of the entrance going in, and then also on the immigration side. We have a question over here.
Yes, hi. I'm from Channel Life Benefits. Getting back to Circular 80 and Circular 82, you mentioned that there are 13 insurers that sort of have low, primary care.
Hopefully I counted properly there on the CMS list, but it's about that.
It's a sizable number.
Yeah.
And although we don't have official figures that are published, there are hundreds of potentially a couple of 100,000 lives under cover. So my question is, what structures are being put in place, possibly by that collective, hopefully, or by individual concerns, to actually fight this regulation? I mean, what activity are we seeing in terms of, players coming together and realizing that their livelihood is under significant threat, and they're really going to challenge this? Because let's face it, up to now, we've been extremely fragmented as a private healthcare industry, looking out for our own interests. There's been very little collaboration, which has resulted in, government really having their way. And I mean, I really think, we're reaching a crossroads. So please elaborate on that.
So if I could comment on that. So yeah, we've recently been approached by some of the insurers to say, can we convene a working group informally? With a possible view that if it gets to the point where we needed to say take legal action, that we could do it through that forum. Obviously, I think that's premature now to go that route, but we need to sort of engage and see. And thankfully, I don't know what will come of it, but the CMS have called a meeting for tomorrow. I think most of us would know about it. It only came out yesterday or Monday, I think.
Yeah.
Monday. So it kind of caught us by surprise. We were hoping to have more oomph today, but no. Anyway, but look, we don't know what's going to come of that. But let's see. I think everyone, it would be illogical not to go to that and see what the sentiment is. Maybe the sentiment is, okay, guys, we didn't realize we can upset so many people. We might change our minds. Wishful thinking. Okay, yeah, good to say. Yeah, but maybe not. So we don't know. We'll see. I think it'll be good to see after tomorrow what the stance is.
Just on that note, if I may, the language that they're using in the first two circulars, as opposed to Monday's circular, is distinct from one another.
Yeah.
I mean, give us a call and we'll tell you how to wind down your business was circular 80.
Yeah.
And then I think the last circular was let's come to a meeting, engage with us, and we'll deliberate on.
I did like the terminology unpack and deliberate, because I thought, okay, why didn't you do that in the first place? Anyway.
Sorry, if I could just, I do think that, just to respond to Anne's questions, is that individual insurers have responded with appeals to the council and UNAs, and so there's been quite a lot of activity, and I think the stance has always been that the more submissions being submitted, the better. So the UNA as well as the insurer and so forth.
Yeah.
So that has been done, I think, pretty much between December and now.
Certain people's holidays weren't so great because of that. But anyway, I think it's worth emphasising a point, though, that there are two appeal processes in the council for any aggrieved party against a decision. So there was initially a thought that it could have been an appeal against the registrar's decision, which due date has passed already. But if you want to appeal Circular 80 or 82, it could be done on a Section 50 appeal in the Act, and the deadline for that is 2nd of February. So it's possible to do that. Look, it doesn't really cost you anything to have it done. It's not like it's not a court case. It's not like legal fees, process. I mean, there obviously be some drafting costs and stuff like that, but to have it done, it can be done. And it's, maybe, as I think what Tosca's saying is if all 13 plus affected parties, because if we add the UMAs and other, maybe even network providers, because they could also be added, we might get to like 25 people who could submit and going, hey.
Coming back to Adrian and all the related employers.
Yes, correct.
Yeah. You could have 1,000 stakeholder groups representing 50 billion in productive economy.
Yeah.
And the prescriptive nature of the document, you should be doing that, right?
Yeah.
So if I could just ask, just further to that then, I mean, we're talking here about the CMS and how we're going to be tackling the CMS, but I mean, the FSCA also has a role to play here. They were a party to the framework, to the demarcation and regulatory framework. So, I mean, what is their stance? Are they supportive? Are they, backing their insurers? Are they taking this fight to the CMS? I mean, what have we done from an FSCA perspective? Or,
Can't comment on
I can't comment on that or on Treasury, because Treasury's involved as well. So,
The Treasury doesn't seem to be having the same tact because simply the fiscus can't provide for it. And that's what they were making clear to Discovery last week.
Yeah.
So they were saying, let's see where this goes, because Treasury's views seem contrary around a lot of NHR.
I think the history of relationship though is that they've always been very diplomatic to say, outside of the internal channels, they won't comment. Like, FCA won't make a comment now about this formally. They'll have internal discussions and then find a unified voice and then come out with a position. So I don't think we're going to get any formal position from anyone. We might be able to engage some to get a sentiment, but I don't think we're going to get anything formal.
You have a question over here?
The implication for us as employers in South Africa is quite dire, and Adrian, you spoke about it to some extent. What should we be doing now in order to engage this significant problem that's potentially 14 months away?
So as I pointed out, part of the concern is that the lack of clarity provided by government doesn't allow an employer to kind of come up with a defined strategy as to what we should be doing. Whether these low-income products are absorbed into a diluted P&B base in order to reduce the costs. I mean, that might be the solution which government proposes. Until those things happen, there won't be a concrete solution now. But what you should be doing is gauging professionals and your stakeholders and your providers so that you can know that you're going to be able to maintain some type of cover for your staff and your members whilst this is happening. Yeah. There's no point in leaving it to the last minute because you're going to get caught with your pants down.
I think the essence of that, or a slight variant to that question, though, is that it creates, all this policy uncertainty creates uncertainty for the employer. And then they say, well, do I really want to do this? And then I'd rather back off and do nothing, which then in essence people suffer from that perspective. So I think the argument I would say to government is that give us policy certainty, tell us what's going on, be transparent. Then employers, intermediaries are advising corporates in terms of what to do aren't left with well, we're not really sure because government isn't telling us what's going on. So
I think just from our perspective as well, I think it's a multi-pronged approach. So the first thing is to try and influence the climate of opinion. So exactly through forums that we're having today, where we've sent out a press release. It's going out to the wider, the popular media and the public. So that's one aspect in trying to inform individuals and consumers of what the impending regulations and what are the implications of the circular. Then of course there's the appeal process and potentially the legal avenues. But I think you need this kind of armory behind the pushback against it. So it's not just one specific item that you can push on and say, okay, well, if we push on that, then we think we're going to be able to kick this thing into touch. So it most definitely is a multi-pronged approach.
Perhaps just a comment, coming back to Adrian, this could be the ironic alternative of mass action. Because if we go bottom up and we go to the employers and say, why don't you just take a poll of your employees? Do you want to keep this benefit? That's not acting on concert from a Comco point of view. We go to all of our employees and our clients and say, survey your staff, do they want to continue this benefit or not? And obviously the 99% will say yes. And then I have 200,000 voters who want to continue this benefit.
So reverse engineering.
Exactly.
Yeah.
So you have a bottom-up mass action saying, hello, we've got 200,000 votes here. Okay, so now how do we talk to this? Because you have nothing else to replace. And or otherwise. And the other part is differentiating P&Bs from primary healthcare from. So I think there are many enabling steps to how you solve the problem in chunks. I think we must not say the government is wrong and we are right. We just don't get out of bed that way. But if we say that there are very good progressive stepwise solutions and we've got a bunch of friends that would like to continue the road with us, I think there are a lot of ways of saying it that way. Then you can use TCF and all the other laws around it to say you must sustain us or provide decent options and all that kind of stuff. So I think that's something that commerce can do very easily and cheaply. So we can all agree the same website, poll all of our staff and they all vote back to the same website. We've got an instant poll. Obviously not on a properly structured basis. So I think there are ways of elevating the stakeholder groups.
I think that medical scheme members will join in.
Yeah.
Yeah, so you can double, triple it.
But I think just to add a bit to this, I think the TCF angle was brought up by someone in the last few weeks with me, and I think that is actually a good thing because they are insurance products. So how's the TCF that their products are just being unilaterally taken away from them? So anyway, or cancelled. I do think though, just to consider that LCBO has been a process in which the private sector has been engaging government to say, and constructively, and without sort of pointing fingers to say, but to now have it unilaterally just pulled out from under our feet is really, really annoying because, you know, there's been so much work from stakeholders behind the scenes. And I think I agree with you that we have to, you know, not get upset and just, you know, try and re-engage. But it's very frustrating that you, as I said, 3 times in 15 years it's been pulled out from under us. You know, when does it get to a point of where there's a genuine desire to not politic, but to actually meet the needs of citizens of the country?
I was at another forum where another accelerated actions being planned. And we talked about the 1 million employed but not insured. So what if we said we'll cover those 1 million within 5 years? You know, so in other words, solve the problem of the immediately insurable population.
And remember, government explored that in mandatory cover.
Yeah.
Remember, there was a point.
So that's fine.
Yeah,
We'll
but they
try
dropped it, yeah.
The only issue is route to market or some quick and easy deployment. We can all put on a standard option. You can create a participating fund. You can do the primary health is always a very similarly structured product.
Yeah.
The point is to get to those 1 million people as fast and as quickly, and then you substitute and solve the problem way ahead of any regulation.
10 million.
Yeah. So to me, that's the issue. Address the 1 million who could be in the population rather than.
Yeah. So I do think that the bigger a sector grows, even if in the sort of level of uncertainty, the harder it becomes for government down the line. And I think if I speak about my own experience, that's exactly what happened with gap cover. So by the time the regulations all come around, there were about 500,000 families on gap cover. You're talking about probably 1.5 million citizens being covered. It was impossible for government to pull it away and say, no, you're not going to have it.
So that I think is the industry response.
I agree.
So just to build into that, has there been any objective, independent assessment of these health policies and the contribution they're making and the service they're providing to combat some of the assumptions being made? And is that another component to the story, is to have an independent investigation to demonstrate that the outcomes are beneficial? Because the government would say that getting more people onto this is more people are getting nailed. So one has to be able to counter that.
Yeah, I think, not that I'm aware of. I mean, it may be worth sort of appointing an independent party to do an assessment, to counter the arguments in there. But I think there's a lot of information that the council has available that still hasn't published in 82, which it could publish, to give us a better idea of where they come. Like, for example, they haven't even told us what the total number of lives involved. Why don't publish that in 82? So why don't they want to? We've got to ask that question.
Andre?
Michael, I actually have a question for you. We speak today about circularity, and sort of a bit about 82, not much, but they said maybe the better, because that is a bit of research, but really poorly research and very biased. But my concern is that 79, which is actually the solution that I offer, will not achieve the objective of providing something that is cheaper. It will provide something that is more expensive, which will exclude more people. So I just want to ask whether my understanding of that is correct. And then two other follow-up questions, and that is the next target your efficiency discounted options of medical schemes? Will Circular 79 also impact your existing medical scheme products to make them more expensive, which I think yes. And then also, is the next line of products also gap products?
Four questions. Thanks, Andre. That's, I think it's going to be hard to unwind gap or demarcation regs, but Yeah, because it was a long fight. I don't see Treasury FSC. They were just going like, listen guys, we've got enough on our plates here. Efficiency discounted options, I've never thought about that as an issue, but the council seem to have accepted, although I actually think technically they're not allowable in terms of how the law's written, they have allowed them, and I think it's a good thing. So I don't see them unwinding that. The second one was remind me please, I'm going backwards.
Existing options more expensive.
The Circular 79,
Yeah.
I think I've had a debate with a number of insurers and medical schemes, and there's not really a clarity as to whether 79 is implying that primary care package is going to be added to the existing PMB package, which then would make it more expensive, or whether that is going to become the new PMB. Either way, to me, they both present a huge problem because if it goes towards the latter option, you're taking away the rights and benefits of now 9 million citizens who have that prescribed minimum benefit cover. But if you're adding it to the existing, the low-cost guys have got no option.
Too
So,
expensive.
yeah, I don't know if I've answered all those questions. So, yeah, okay, thanks, Andre.
Your response there, Mike, just being around the gap cover and your view that government's going to let that be. And I hear your point that you make with regards to the length and breadth of the discussions that have taken place to date. But the length and breadth of the discussions that exist in the LCBO space have also been ongoing for a long time. So I'm not sure that sense will prevail when considering alternate products as well. Just a comment.
No, look, I think I hear your point. The only difference I would say is that nothing's ever been promulgated around LCBO or LIMS or anything. It's always just been discussions, whereas demarcation's actually now been promulgated, passed, it's in law. I think it'll be much more difficult to unwind. I mean, it's not impossible, but yeah, look, I mean, who knows? In the world of politics, I suppose anything's possible.
Any other questions? Okay, I'd like to thank both our speakers for your excellent presentations today, and I'd like to thank you for attending. It's exactly because of these type of forums that we're able to get the information out and to share it and to influence the climate of opinion, which is what I was referring to earlier on. Please do attend tomorrow and ask the hard questions, because I think that's is going to be very important to push back against this latest circular. So thank you for attending today.
Thank you very much for your time.